My name's Terry Lockhead. I work with the Alliance for Retired Americans, and I especially work with the board of the New Hampshire Alliance for Retired Americans. That's a chapter of our national organization here in New Hampshire. And I just want to point out a few of our board members who are here. Charlie Balbin here. Charlie, can you wave? This is Charlie's the president of the New Hampshire Alliance. And Ron Jeffroy, who was standing here, over here with the beard, is executive vice president. Caroline French is in the back here with the brown sweater. And Jerry Connor is behind the camera here at the Londonderry Public Access Television. And we also have Channel 13 here, so we're glad to have you all. Welcome. Just very briefly, I'm going to introduce Rich Fiesta, who is the Director of Government Affairs for the Alliance for Retired Americans in Washington. He's our chief lobbyist. He really knows what he's talking about on this subject of Medicare and Medicaid and Social Security and what Congress's plans are. He has been with the Alliance since its founding almost 11 years ago, and he has spent virtually his whole career in health care and retirement issues. So Rich, welcome and thank you very much. We're going to have Q&A when Rich is done, and I hope you'll all think of a question.
Thank you, Terry, and I appreciate very much the invitation from the New Hampshire Alliance to come and speak this evening about what's going on in federal budget issues, in particular since the U.S. House of Representatives last week passed a budget that, if it became law, would have very significant impact on programs like our retiree organization cares about, Medicare, Social Security, Medicaid, and other senior programs too. As Terry mentioned, the National Alliance for Retired Americans was founded in 2001. We're about 4 million members with about 1,500 chapters, local chapters around the states, and including the New Hampshire Alliance, which has more than 13,000 members. So glad to be here again. I've been invited by the New Hampshire Alliance on several occasions to come up and speak, and glad to be doing it again this evening. As I mentioned, the U.S. House of Representatives passed a budget last week introduced by a Wisconsin congressman named Paul Ryan, who was chairman of the House Budget Committee. He became chairman in 2011 after the 2010 elections, when the Republicans became the majority in the U.S. House, and he is a member of Congress from Wisconsin. This budget passed by a vote last Thursday, the 29th, 228 in favor and 151 against. And as I mentioned, it has a number of provisions that are particular to seniors and retirees, affecting their health care and their Social Security as well. And this evening I'd like for a few minutes to kind of outline what those are and how they affect older Americans. One thing the Ryan budget does is repeals the Affordable Care Act, which was passed in 2010 immediately. And the many provisions in that law, the Affordable Care Act, which just celebrated its second anniversary 2 weeks ago, there are a number of provisions that directly change Medicare that have been into effect and would be repealed should this budget become law. In New Hampshire, there are about 222,000 residents on Medicare, and that's about 16% of the population here. So that's 1 out of 6 people. If you walk down the street, on average, 1 out of every 6 people you would see passing by would be a Medicare recipient. Most are over the age of 65, which when you get your insurance at age 65, but also a number of people who are disabled also qualify for Medicare a while, and that's about 40,000 in New Hampshire. So it's a very large number of people. 1 out of 6 in New Hampshire are directly affected by Medicare. And the Affordable Care Act a couple years ago had a number of provisions that have helped seniors with their health care that's been implemented in 2011 2010 and 2011, and now into 2012. One of those is that the ACA, as it's called, Affordable Care Act, now allows for Medicare recipients to receive most of their preventive screenings and checkups free. That is, in other words, they don't have to pay a copay and they don't have to worry about a deductible. So screenings for diabetes or prostate cancer or mammographies or colonoscopies, a whole number of things since 2011, actually since 2010, have been free to seniors. And the HHS, the Department of Health and Human Services, came out with statistics a couple weeks ago saying last year in New Hampshire alone, 163,000 people took advantage of these free preventive services, and or you get an annual wellness checkup too now with your doctor under that law. Also, some of you may have heard, if you're on the Part D Medicare prescription drug program, which was passed in 2003, there was something called a donut hole, as it's referred to, that after your spending for your drug costs got up to about $2,300, $2,400 a year, then you had no coverage until your spending got up to about $4,000 or $5,000 a year. That was known as the infamous donut hole, where you'd have to pay your premiums every month to the insurance company, but you wouldn't get any benefits because of it. Well, the Affordable Care Act is slowly, over the next 8 years now, till 2020, shrinking that donut hole so that you won't be lost without coverage. And in the meantime, seniors or Medicare recipients who are in that donut hole get a 50% discount on their brand name drugs. And last year, a 7% discount, and this year it's a 14% discount in 2012 and onward on their generic drugs. And as we all know, drug costs are very expensive, especially in the brand names. And HHS has said that last year alone in New Hampshire, a little over 13,000 people got relief in the donut hole with this 50% provision, and each person on average saved $621 in their drug costs because of the provision in the Affordable Care Act. So the statewide savings was a little over $8 million, and that will only grow over the next few years as that hole gets smaller as well. So there are a couple of things such as this which directly benefit seniors, donut hole, preventive services and all, and some things where the Affordable Care Act has helped the state. The state of New Hampshire received $500,000 for aging and disability resource centers around the state to help people who are either aged or disabled under Medicare receive better treatment, and another almost $200,000 for the state to do outreach to Medicare recipients too, because folks, a lot of folks just don't know that some of these provisions, especially in the wellness and the checkups, are now available to them. All of those, and there are many other parts of the Affordable Care Act, but all of those under the Ryan budget would be repealed immediately. So we'd go back to having a donut hole. You'd have to go back to copays and deductibles on your screenings as well. So that's kind of one thing I wanted to bring out first of what some of the immediate happenings would be should this thing pass. Now, looking forward, looking more long-term, the Ryan budget also takes a very different tack, very different path for Medicare. It would essentially change Medicare over the next 10 years. I mean, as we all know now, Medicare, enacted in 1965, covers everyone over 65, or if you're disabled and under 65, you can qualify. And it's sort of one-stop shopping for health care, that you go to your doctor, you receive the treatment, there's a schedule on deductibles and copays and premiums every year. The government, through the Medicare Trust Fund, reimburses your health care provider under a set schedule, a doctor, a hospital, or if you need some sort of medical equipment. And that's how it's worked since 1965 at a very low administrative rate. 1 to 2% goes towards administrative costs. The Ryan plan, however, would change that dramatically over the next 10 years. It would eliminate the guarantee of the one-stop shop of Medicare and replace it with something similar to, if you're familiar with the Part D program, of allowing private insurance companies to come into the Medicare market to replace the one-stop shop of original or traditional Medicare. It would be a voucher-like system where that everybody born after 1958 would be required to participate in when they reach Medicare age. So that would happen in 2023. So if you're born in 1958 or after, you would automatically be covered by this plan. The government would subsidize the insurance companies that would come into the Medicare market with a fixed amount every year based on a complicated formula that really has been less than what rising healthcare costs have been every year. It would be the gross national product plus 0.5%. But I think anyone who's dealt with healthcare costs over the last 15 or 20 years know that there's been a little more than 0.5% inflation every year. So the question is, what do you do with that gap between what the Ryan plan would do and the true healthcare costs under Medicare? And the answer under this plan is the beneficiary would have to pay for it out of pocket. It would reduce how much government would spend on Medicare, but it would vastly increase what individuals who are Medicare beneficiaries would be paying for their health care every year. The plan would allow Medicare, the government one-stop shop, to continue, but it would create a tension, if you would, between these private plans that would come into the market and traditional Medicare. And we can see some of that's already happening now, where Medicare, the traditional Medicare, competes now with these Medicare Advantage plans, or Medicare HMOs. And what we've seen with those over the last 5 or 6 years is that the Medicare Advantage plans have been able to take away the healthiest seniors who have the lowest health care costs, while traditional Medicare, the fee-for-service one-stop shop, has been left with an older and more sick, more healthcare costly population. If we extended that to all of Medicare, the whole system, you could see over time that the traditional Medicare, especially with these flat payments, in some ways would be withering on the vine, as someone once put it, and in some ways could become uncompetitive. So we at the Alliance are quite worried about this proposal. It would, as I mentioned, start for anybody born in 1958 or afterwards. I think a couple things are there to note. That the average Medicare beneficiary in this country only has an income of about $25,000 a year. And only about 15% of Medicare beneficiaries have an income over $50,000. So what this Ryan plan is doing, it's asking people in those income ranges to pay more and more out of their pocket as the years go on, as this new plan would go into effect. It would immediately, in the 2020s, you'd probably be paying $100 to $200 more a month out of pocket, plus whatever premium increases would be going on as well. So that has us quite concerned. A second part of the Ryan plan on Medicare is the plan actually increases the eligibility age for Medicare. Right now, and since 1965, you turn 65, you go on Medicare, unless you're disabled, and then you can get it earlier. The Ryan plan would actually increase the eligibility age to age 67, starting in the 2020s, about 10 years from now. And what has us concerned on this is that if you repeal the Affordable Care Act, which has guarantees of coverage in it up to age 65, and you replace it with this new Medicare system and a higher eligibility age, then what happens to the people who are 65 and 66? They won't have a guaranteed system to go into and buy private insurance if you repeal the Affordable Care Act. So they would be left much the way people now who are over 55 to 64 are. Those are the hardest people who have the hardest time to try and get insurance And then you put people who are even older than 65, 66 and 67 under the Ryan plan out there in the market too. I don't think you'd see the insurance companies running up to people with senior affairs saying, hey, here, you know, we want to insure you, which is why we have Medicare in the first place, that older people who obviously use the healthcare system more than any other segment of the population can't get private health insurance. The system, the markets just don't work for that age group, which is why Medicare came into being in the first place. The Ryan plan would even make that worse by pushing it 2 years later to 67. And it's even unlike Social Security, where under Social Security you can get your early benefits at age 62 if you need them. You get a reduced benefit, but it's based on your life expectancy, so it's all supposed to work out. But at least under Social Security, you can come and get early benefits. And what we've seen during the recession in the last 3 years, 4 years or so, is that more and more people who are age 62 or becoming age 62 have applied for Social Security just because the job market, especially for older workers, is very difficult. And Social Security is there as a way to counteract the economic hardships that they're going through. Under this Ryan plan, however, there's no early in for Social Security. You can't buy partial coverage, for example, or pay more to get coverage. You would have to wait until you're 67. So that's an issue that we think a lot of people would have problems with, as they say, out in the real world, as it were. Ryan plan also talks about the other great retirement plan, Social Security. Just looked up today, there are 260,000 people in New Hampshire receiving Social Security benefits. That's retirees, surviving spouses, children who are dependents. It's a larger program. It's almost about 35,000 more people receiving Social Security here than are receiving Medicare. And again, that's about 18 or so, 19% of the New Hampshire's population. So that's going down the street, and maybe 1 out of 5 people you would meet on the street is receiving some sort of Social Security benefit as well. The other thing I want to mention about Social Security under the Ryan plan is that he would fast track changes, much like we saw fast track with trade agreements, with some base closing as well, that should government spending hit a number on the GDP, as it's called, then would have automatic cuts across the board, and Social Security would not be spared. So in terms of what would happen there, again, that's a very troublesome provision for our organization. So going forward, those are kind of the basics of what the current budget passed by the U.S. House is. Prospects in the Senate we're unsure. The Ryan plan did last year go to the Senate and was defeated, but we're unsure exactly what procedures will happen now in the coming weeks and months. So I think, from what I understand, it'd be a good time to take questions, or we can talk some more about it.
That'd be great.
Good.
Rich, if you could repeat the questions, then we make
Sure.
sure we get them on camera. Thanks.
Sure, we'll do it in the audience.
I just need clarification.
Sure.
On something. You have to go on Medicare at 65?
You have to for Part A, yes. Part B, Part A is the hospital trust. Part B is up to you. That's what your doctor, your physician is. But 99.99% of people do go on Part B. The question was, do you have to go on Medicare at age 65? Mm-hmm. Yes, someone else, please. Yes.
I think I know what Jean Shaheen's position is on this. What about our other legislators in the state?
In the state. Well, in the House, both the New Hampshire representatives, Junta and Bass, voted for this. Ginta, excuse me. My name is, I'm Italian American, so I pronounce it the old style. Ginta and Bass voted for it. Yeah, someone else with me. Yes, sir.
Voted in favor.
They voted, yes, they voted in favor of the Ryan proposal. Yes.
A procedural question. If, God forbid, the Paul Ryan that mean everything in the budget automatically goes into place? Or do each individual items have to be rescinded, like the affordable health care?
Correct. If you went completely to the end with the House and the Senate to get to his budget numbers, there's, as you mentioned, there's a process called rescission that the House and the Senate then go through before the final budget. And if they agreed to the Ryan language, then it would become part of the law. So law, it would repeal provisions and therefore or repeal totally the Affordable Care Act, and then would create this new system of Medicare delivery. Yes, ma'am, in the back, please.
At the present time, if you become disabled, say when you're age 40, and qualify for Social Security disability at that point, 2 years from the time that you get your Social Security, you're eligible for Medicare. Now, how does the Ryan budget impact that? Is it exactly the same as those who are doing it
Right.
for seniors?
Right, the question was how would the Ryan budget impact people who are less than 65 who are on Social Security disability, and current law is that once they receive their Social Security disability benefits, they must wait within 2 years before they can go on to Medicare. And obviously, if you're disabled and you have to wait 2 years, a lot of us think that's too long of a waiting period and can produce a lot of hardship. Under the Affordable Care Act, starting in 2014, if it's implemented, you would be able to buy insurance through a group in your state called an insurance exchange. Under the Ryan proposal, if the Affordable Care Act is repealed, that would not be available, and you would be exactly where we are right now, disabled and let's say in your 40s or 50s, trying to buy insurance on your own.
And if they have, give this lump sum payment to everybody, at that point to go out and buy insurance on the open market, it would be an equal amount then for those who are disabled at that time?
The question was on premium help, as it's called, for people who are disabled. Under the Affordable Care Act, it would be based on your income. Under the Ryan plan, it would again be based under current law as well, but you wouldn't have a lot of these protections. Some states may have better protections for people trying to buy insurance, pre-existing conditions, and whether or not you can be turned down or not. So a lot of it would get turned back to current law, and then you're state by state in many ways. Yes, sir, in the back.
And there's another budget plan out there that's been co-sponsored by Charlie Bass. And it's based on the Simpson Bowl Deficit Reduction Commission. Can you tell us a little bit about that and how that might impact Social Security and Medicare?
Sure. The question was during the Ryan debate, there were several amendments. He's referring to one that was based on the Simpson Bowles Fiscal Commission from last year. It was first offered by Congressman Cooper from Tennessee and was co-sponsored by Congressman Bass as one of the original co-sponsors here from New Hampshire. What that amendment did, and it lost badly, only 38 people voted for it and 382 voted against it. So it was a real bipartisan rejection of the Cooper amendment that Congressman Bass co-sponsored. But it tried to bring in some of these other budget numbers that this Bowles-Simpson group tried last year. In other words, just saying the government can only spend so much money no matter what fiscal health, if we're in a war, if there's a natural disaster, it almost doesn't matter, and somehow try and reduce the deficit for that. The problem with this Cooper amendment was even unlike Ryan, it even went further on the health care, because Ryan at least acknowledges you're going to be getting paid less through Medicare, which means the beneficiaries will be paid more. The government will be paying out less. But at least Ryan represents a budget that knows that there are going to be more people in Medicare 10 and 50 years from now because the baby boomers are retiring. The Cooper amendment that Bass co-sponsored didn't even take that into account. So the government would be spending the same amount of money on a much larger pool of Medicare beneficiaries. So the beneficiaries would have to be paying even more out of pocket under this plan as well. That amendment also set in place potential cuts to Social Security through, again, freezing government, which means it calls for a 10% cut in federal employees, which means a 10% cut in the number of Social Security Administration employees. And for people on disability or applying for disability, right now they have to wait about 350 days, well over a year, just to get their case heard. Now you take away 10% of the personnel, the backlog would even get worse. They just in the last couple of years have worked it down from about 500 to 600 days. So there are, implications right across the government, just not on, easy things to look at like Medicare and Medicaid, for example.
Are you going to follow up to that?
Sure, same price.
I guess the assumption would then be that if the Ryan budget passed the House and is not in front of the Senate, it could be introduced in the Senate, voted on, passed or fail. If it fails, there's still a possibility of it coming back up next year, where they would be reintroduced with potentially a new House, a new Senate, possibly Republican-controlled, and maybe Republican-controlled in the White House, which could ultimately pass the Ryan budget. Is that correct?
That could happen. The question was, what if should the Ryan budget not make it all the way through next year? What could happen in a new Congress in 2013? Right. And we can't predict what the elections would be, but if all two branches, both houses and the White House, were of one party, and Ryan were still chair, it would have a much greater chance of passage. I'm almost certain. Another thing I think on that same line is last year when Congress passed the debt ceiling limit last July and August, part of that was they created a super committee which was supposed to find $1 trillion in cuts to help the deficit. Super committee couldn't do that in 3 months. So then automatic cuts, which is under current law, are supposed to take place in 2013. Now, Social Security and Medicaid and the beneficiary side of Medicare are all saved from these automatic cuts. The budget word's called sequestration. However, a lot of other things are going to happen this year. The debt ceiling's probably going to have to be raised again by the end of the year. A number of tax cuts are expiring at the end of the year as well. The way Medicare doctors under Medicare are paid is expiring. So we could have a lame duck session in Congress, and maybe not all of these plans, but part of them could work their way into the conversation or into final legislation. So I guess the point is, if the Ryan budget isn't 100% that's going to make it through the House and the Senate this year, it's even less than 50%. Elements of it could find its way into other parts of what has to be another budget debt issue and taxes sometime late in 2012 or early 2013. Yes, sir.
Thank you very much for coming. I'm more of a commenter than a questioner. When you go back, at least you bet one senior citizen who's willing to pay 100% on his Social Security. I think that's one way we could show that we're not just thinking about ourselves. I find it's very often the case that we're not that, some of our people are not that much different from the people on the other side taking the voting themselves. We should see it in the whole country. And then about vouchers, my opinion is vouchers have proved themselves in education and other things as a jack under the floor. They can't help but keep raising the cost because you give you certain money to pay, and the private companies can raise it. Only public institutions can't raise their prices willy-nilly. So, and Simpson Bowles, they tried, but we have to remember there was a conservative, Alan said, Simpson Republican, and a conservative Democrat, and they worked their system. But they also have something completely outside of the matching the budget to take care of only 2 brackets. That's all side point. That's still a soft point. 2 brackets. There should be at least half a dozen. The computer doesn't know the difference between what 2 brackets is. Let's get up to it. taxable income. It doesn't care whether you have 2 brackets, 20 brackets, okay? It's all built in. So that was a philosophical choice on two choices, Mike. I appreciate you coming. I think I learned lots of this.
Thank you. Yes, no, back there. Yes, sir.
I think we all realize Medicare and Medicaid and not quite as bad, Social Security are in need of some changes. What's the New Hampshire Alliance for Retired Americans solutions to getting those programs back up?
Sure. The question is on keeping the financial or fiscal health of Medicare and Medicaid and Social Security. Well, a couple things we've seen already just in the last year or so have helped. The Affordable Care Act ratcheted down the payments that these Medicare HMOs or Medicare Advantage plans have gotten. They were an idea 10 years or so ago that they could compete equally with Medicare and provide better service. Well, the government auditors have found that they're receiving on average 14% more than what the cost of treating the same person for the same illness would be under regular Medicare if you just went to a doctor and didn't buy one of these plans. So the Affordable Care Act is ratcheting down those what are called overpayments to them, and the government auditors have said this will add another 6 to 8 years to the health of the trust fund, to the Medicare trust fund. It was supposed to go bad or flip in about 2016, 2017. They've now pushed that in to about 2022 or so. Easy way. You want to save $137 billion over 10 years? Very simple. Allow Medicare to negotiate for prescription drug prices under the Part D plan. I mean, it's a very simple thing to do. Every other industrialized country does it for their health system, some of which have private insurance, like we do, some of which are much more all public insurance. And our neighbors here to the north can do it for a population of 35 million. I mean, Medicare itself is about 45 million, just, over 65 or disabled. All of Canada's what, only 35 million. But the government auditors have said that's a simple thing to do, $137 billion over 10 years, just if you could get Medicare to negotiate. Because the 2003 law that created Part D expressly forbids Medicare for doing that. So instead you have is you have a fractured market of these Part D companies cutting their own little negotiations rather than the bulk purchasing that the Veterans Administration can do for prescription drugs in the VA system. The Department of Defense can do it in DOD hospitals. The Indian Health Service, which is important in the western part of the state, does it. So those are 3 government programs that are saving the taxpayers' dollars by doing that. Another simple way of about 25 billion is, this was another little loophole created in the 2003 law. The 2003 law said that people who are under Medicaid for their prescription drugs will now be put under Part D in Medicare. Well, under Medicaid, the states could negotiate with the drug companies for a lower price, but under Medicare, they can't by law. So these people who are called dual eligibles, they're over 65 or disabled, and their income is low enough that they qualify for Medicaid, are now for their drugs covered by Medicare, which are costing more for those same drugs if they just stayed in Medicaid. And that's another 22 to 25 billion over 10 years that you could save very easily. In fact, that's in President Obama's budget for this year to change that. And of course, the drug companies aren't real happy about that, as you can imagine. Yeah.
Is it true that Americans fund these drug companies R&D for the development of drugs in the world?
Yeah. The question is, do we fund drug company R&D? Directly and indirectly in many ways. I mean, the National Institutes of Health fund a lot of the studies and protocols and basic research, even before there's a drug, just way down there at the micro level on that. And then they give grants out to hospitals and labs and research universities and sometimes the drug companies' arms as well. So, you know, drug development in the world, I mean, we, the U.S., are by far the leaders. You know, we're well ahead of Japan and Western Europe, and they do develop, but not to the extent that we have. So it's basically, yes, our tax dollars funding these new drugs. You know, they've been great things over the last 20 or 30 years. Saved a lot of lives and saved a lot of, you know, otherwise hospital costs, doctors' costs as well. But we're not getting a lot back for it that way, are we? Yes, ma'am.
I just want to make a comment. All of the drugs that we develop here and whatever, I then outsource to production facilities overseas.
Mm-hmm.
My husband goes to India every other year, and I send him with, don't take my name down. I send him with a list of prescription type things that I'm going to have. And those are exactly, and he comes back with this stuff that is exactly what you get in your pharmacy at maybe 1/40th of the cost.
Mm-hmm.
It's amazing. And so it just, it bothers me that the drug companies say, well, they have to pass our standards. Well, they're importing all those exactly the same things. They're just acting on a tremendous amount of money.
Yeah, the question was on drugs from created overseas versus, I guess, the costs we pay here and how much cheaper they are overseas for the same things. As we like to say, you know, sadly, Americans pay the highest prices in the world for prescription drugs. And that didn't happen by accident. Didn't happen by accident at all. And part of it is these fragmented markets in Medicare, the inability to negotiate for drugs, patent protection. There's a move to stop some sort of sweetheart deals between the brand name and the generic name, that they can have contracts where they don't, the generics pay the brand name, or the brand name company will pay the generics, so you don't see the generic cost as a lot lower than it should be. But the Alliance, when we first got started about 10 years ago, we did from New Hampshire, ran bus trips to New Hampshire. We did it, we found Canadian doctors and put our people, they met with the Canadian doctors, they wrote a Canadian script and then had it filled in a Canadian pharmacy. And the most galling one of these is tamoxifen, which is used for breast cancer. That there's one of these contracts here in the U.S. between the brand name and the generic, that the tamoxifen price in Canada is 90% less of what it is in the United States. That's probably the most glaring one of these, but a lot other 20, 30, 40, 50% less. Yes, sir.
I have a friend that left today for England with some tests in minor operation. He has dual citizenship. He's American. He's been there for 30 years. And he's going to have the British government going to pay for it all. And it's cheaper to fly to England and have this work done than it is to have it done here in the States.
My comment was how medical care, the cost for a friend of his who's a dual UK-US citizen is cheaper in Britain than it is here, and he's actually flying to have it done there. Yes, sir.
On this point of the difference in prices, actually today or yesterday's Telegraph, Canadian drugs get okay. But there was an article in the Times just recently that you give up your right to sue by getting the generic. If something goes wrong with a brand name, you can sue. Unbeknownst to most people, including me, that if you got a generic and something goes wrong with that drug, I don't do that. You gave up your right to
It's
sue.
difficult in a lot of states. Yes, sir. So,
it's interesting. I worked for a drug company for 20 years, and so I'm sympathetic with their problems too. Interesting thing happened recently. Lipitor, which is Pfizer's drug for cholesterol reduction, lost its patent. They developed a price strategy that they would drop the price of Lipitor now, if you buy it in the pharmacy today, so that it's lower than the generic in order to perhaps control the market and run the generic out of business. I don't know what their scheme is, but I suspect that's what it is. Second question. Is it illegal to buy drugs in Canada where the script is written in the U.S.?
That, I think, is up to Canadian law and how a Canadian pharmacy, I think, would want to handle it. Oh, sure. Oh, there you go. Fine. I don't believe that if you bring a U.S. script to Canada, you can, well, it's again under Canadian law whether or not a pharmacy can fill it there. Because it, now, I do know that some Canadian provinces, particularly New Brunswick, because our people in Maine do this, the province of New Brunswick, found a little revenue raising, that they'll allow American doctors to pay, if they're in good standing, about $250 or $300 a year to the province of New Brunswick, and then they'll get the authority to write Canadian prescriptions in Maine. So our members then go to a U.S. doctor in Maine, and they can get covered under Medicare for the visit, and I don't think this is... No, it's here. So their visit can get covered under Medicare, and then they'll have a Canadian script they can take across the river to Maine to fill in a Canadian pharmacy. So the province of New Brunswick got a little entrepreneurial. And the pharmacists in New Brunswick like it a lot, too. Yes? Yeah. Oh,
there is a website that you can order drugs on, and they do get them from Canada. So I don't know what it is, but I haven't used it. Also, I have one more question. What is the Alliance doing in terms of lobbying to make it so that maybe this Ryan will won't get passed?
Right. Well, a lot of it is, we're a grassroots kind of organization, so our folks back, in the states and in the congressional districts, we try to do a lot of, local grassroots visits to the office of local U.S. representative. Right this week, starting yesterday, and well, actually starting today, and next week, Congress is in a 2-week recess for the Easter Passover. So it's a little late for the Ryan budget, but we're going to say thank you to those who voted with us and ask those who didn't why they didn't. And there'll be other opportunities coming up this year and a whole host of things too to get out and get our position known. And in fact, having a forum like this is one of the ways. Someone, yes, ma'am.
I just wondered what happened to that busing program to Canada.
Right.
Why is that? Is that still in existence or not?
Well, with us, it was a 4-letter word called SARS. Remember that?
Oh, yeah.
Yeah. We did it early in 2002 and 2003, and then the SARS epidemic hit Canada, and you don't want to send American seniors into a situation. Well, I mean, in fact, there were armed guards at hospitals in Canada for a while, and only essential people were allowed in. So the SARS epidemic, 03 and 04, kind of closed it down for us anyway that way. And plus now there are some internet availabilities, like the lady said earlier too. Some states have actually, and in Wisconsin and Minnesota, have sent people into Canada from their state governments to kind of bless pharmacies, so to speak, and put them on their state websites. Yeah.
What's the Alliance position on means testing?
Means testing in the social insurance world, which is Social Security and Medicare, we feel doesn't belong there, because no matter how much money you make or don't make, what you put in for your benefits, like a premium, you should get out in equal benefits without regard to what your other income is. That, for example, in Social Security, I mean, we all pay in the same up to that earnings cap. That this year, if you make $110,100 and above, you don't pay anything into Social Security. But the benefit structure will be the same on your retirement, whether you make $50,000, $5,000, or $500,000, because of the benefit formula that we all paid into. And the same thing with Medicare, although under the 2003 law and then later, there's now some means testing in Medicare Part B for the hospital, for the doctor's part, excuse me. If you make $80,000 or more a year, or if you're a couple, you're at 160. And now it's going to be instituted for the Part D drug program as well. But to us, that basically undermines what is an insurance nature of these programs, that they aren't welfare programs, that they aren't means tested. You know, I like to say, if you buy a $100,000 life insurance policy, you know, if you make $20,000 a year or $500,000 a year, you still pay the same premium for that $100,000 life insurance policy, and you collect, or your survivors collect $100,000 no matter what your outside income was. And we kind of feel the same way on Social Security and Medicare.
Charlie Bass has been sending out a lot of very slick ads in the mail, and to me they're extremely misleading. And he's putting himself up somehow a champion of the seniors, a champion of Medicare, a champion of saving ourselves from the death panels of the world. And I want to know how the Alliance's plans are to out him with the truth.
Well, no matter who they are as a member of Congress, if they're with us or against us, you know, we have our principles, and having forums like this, you know, allows us to, you know, explain our position and say where people voted. I mean, obviously, he voted against the Ryan budget, well, last year and this year, and that's just a position we don't agree with. Yes.
I think the problem that she was talking about is that Charlie Bass has redefined Medicare and Social Security. So when he says Medicare, or when he says Social Security, it's not what I have. And we have to know what he's talking about. And what he's talking about is not what we have now.
Yes. Oh, yes. You, behind the camera.
Since you brought Charlie Bass up,
Someone did.
last fall, a group of us went to a wellness fair in Hudson. And it was kind of a nice event. They were checking your blood sugar and your blood pressure, and there was somebody from Medicare there and talked to him. And Charlie talked a little bit. To his credit, he decided that he would sit down with a group of us in the Alliance. So one of the questions that we asked him was, why not raise the income cap for Social Security? His response was, if we do that, you're going to have Social Security recipients who are going to be getting checks for over $100,000 a year. You want that. Is that true?
Not in this century. Maybe inflation into the next century will get us there. Yeah. As we know, Social Security is funded by withholding on workers. Sure. The question was that they saw Representative Bass at a health fair, asked why one way to help Social Security out is to raise the earnings cap. He responded, well, then you'd have people making or having benefits that could be $100,000 a year. Social Security is funded. I mean, Social Security is a private system. There's no federal money in the system. It's 6.2% of a worker's salary, although last year and this year it's been reduced to 4.2%, and 6.2% of the employer's salary, all put into the trust fund. And even the workers at the Social Security Administration, the administrative costs of Social Security come out of that trust fund too. Other federal money does not go into it. Last year and this year, this payroll tax holiday for 2 years to help get more money into the economy, because it's people earning less than $110,100 who the economic theory is they'll spend it if it's given back to them or not withheld. It's 4.2%, with the money for the first time in the history of the program is being made up by the general revenue of the United States. Well, historically, the way Social Security has worked is if you added everybody's wages up in the country, from someone working part-time all the way up to Bill Gates's wages, and you came up with some big number in the trillions, 90% of all those covered wages, would be covered by the Social Security earnings. Well, what's happened over the last 20 years is we've sort of had a skewed earnings curve. We've had more people at the top having a higher percent than everyone else. So what has happened is that 90% is now down to about 82 or 83% of all wages in the country. One simple way would be get us back to the historic level. Would probably solve about 30%, 35% of Social Security's predicted shortfall, which is only 2% over 75 years. In other words, the auditors say by law, Social Security has to do its books and its projections over 75 years. I mean, no other government agency or corporation or anybody does a 75-year projection. You know, IBM, GE, or the government in New Hampshire, they just don't do that. Normally 30 years for pension is about as far as you go. But Social Security's at 75. So we're 2% short over 75 years. Fixing the earnings cap to its historic level, much like we raise the minimum wage every few years, would close about 30 to 35% of that gap right off the top. And then you would still have people, you know, above that who wouldn't be paying in. There's other loopholes. Not every dollar you earn, even if you're under that cap, is covered by Social Security withholding. If your company offers a health savings plan, or HSA as they're called, or FSA, or some of these other benefits, you will pay income tax on those earnings, but you won't have Social Security or Medicare withheld. And that's just frankly a loophole that allows companies not to pay their 6.2%. It's almost an incentive to offer those high deductible health insurance plans and supplement it with an HSA or an FSA. And that is bad, we think, because the worker doesn't get credit. Sometimes if you're putting $3,000 or $4,000 away into this plan of your own money, you're not getting credit for that $3,000 or $4,000 over your lifetime earnings. So compound that over a few years. So your benefits at retirement won't be high. And the Social Security Trust Fund isn't getting money from those earnings as well. That would close another 15% of this shortfall over 75 years. So there are ways to do this. If you blew the cap off, like Medicare, since 1993, we've all been paying 1.45% and 1.45% from the employer side on Medicare. If you did that with Social Security, although it's a much bigger number, you could actually increase benefits as well.
I just, one thing you said, that they're the only entity that has to pay 75 years. I think now the Postal Service does.
They might. In fact, their pension fund is so overfunded right now. There are some in Congress that want to, bring it back because the Postal Service obviously has other problems, and this maybe help their obligations. 75 years is a long time. Can have a couple booms or busts in hand. Yes.
On the, just to follow up on the Social Security deal, something I don't quite understand. Is there a cap for the recipients based on their contribution rate over their lifetime?
Yes, and that fluctuates year by year. I think the maximum this year that an individual can get per month is around $2,300, $2,400, and that's based on the formulas of what they, put in through their years. But that's it. The other thing about Social Security is, the average Social Security payment or income is about $14,000 a year. I mean, they aren't overly generous benefits. It's, basically around $1,200 a month. And for women, it's even less because women are more in and out of the workforce during their working lives and oftentimes at lower paying jobs. So theirs is a little under $1,100 a month. So when you compare our social insurance, Social Security, to other countries around the world, the industrial countries, there's a worldwide group that's about 35 industrial countries, and we're always about 27 or 28 in the generosity of our Social Security benefits compared to our peers, as it were.
I was in a meeting last week, and a retired social worker happened to mention that one of the concerns she has about the Ryan plan and Medicare has substantially changed is that things will go back to the way they were when she was a social worker in the 60s, whereby senior citizens would choose not to accept help for their medical bills because if they did, the state, she worked in New Jersey, the state of New Jersey would get income statements and asset statements from all their children and tell them what percentage of their relatives' health care expenses they were responsible for. And she says there's a lot of states that still have those laws on their books. And recently she read that someone in Florida, a senior citizen in Florida, their child in Maine, adult child in Maine, got a letter from Florida saying you're responsible for this percentage of your mother's medical bills, and they put a lien on these people's loans. I don't think, is that?
How can one state put a lien on somebody
Yeah.
else's
And how do we let
property in
people
another
know?
state?
I am that worker.
She's right, did I do a good job?
Yeah, you know, the one thing is that I said the wrong thing in Florida and Maine, it was Philadelphia and Florida.
Oh, okay, sorry.
And I have that article here that I'll give to you, you know, about legally responsible relatives.
It's you know, we're going back to a kind of, remember the old county poorhouse kind of things? I think all of us grew up with those. I mean, that's, for a lot of people, the way the world was, you know, pre-Medicare. It wasn't the happy Walton family living up on the hill with grandpa and grandma, you know, out on the farm. You know, and plus, you know, with this recession, the state governments, you know, you can see it here or anywhere, have been so strapped for cash, they're resorting to kind of these old, you know, dusty things on the books that they're off. Clearly, the states don't have any funding to do this.
New Hampshire does have a law that's not enforced on the books that children are responsible for their parents' deaths.
Do we have one last?
Convince Congress to allow these states to set up their own Medicaid and Medicare systems with a type of a block grant. And it actually did pass our legislature here. We don't know what's going to happen on the national level, but there's a lot of chicanery that goes on in our legislature, and I just see what's coming down the pipe, that they're going to rob. They have no conscience about robbing various trust funds and things like that, and they'll be taking Medicare and Medicaid money and using it to fund other state obligations and leaving nothing, you know, nothing for other people. You know,
And it is Medicaid and Medicare.
Yeah, and Medicare too. I don't think, yeah.